Hello, everyone. I'm Dr. Mark Stebbett, co-president of HPV Global Action, and I'm pleased to serve as moderator for today's program. I would like to thank you all for joining us for today's continuing medical education webinar presented by HPV Global Action and the Consortium for Infectious Disease Control. Today's presentation is entitled "The Rate of HPV Head and Neck Cancers is Rapidly Rising. What More Can Be Done in Prevention?" And we're very fortunate to have three international experts on the program today, Dr. Melissa Henry and Dr. Denis Soulier, and head and neck cancer driver, Dr. John Peter Bradford, to provide this very important presentation on this International Day of Awareness of Head and Neck Cancer. I would like to thank Merck Canada, whose support has enabled this webinar to be provided at no cost to participants. Today, we have 6 objectives. Our presenters will address them in order. So to describe the burden of disease of head and neck cancers in Canadian, explain the complexity of challenges for patients with head and neck cancer, review the efficacy of HPV vaccine to lower burden of head and neck HPV cancers, to recognize signs and symptoms of head and neck cancer, discuss potential screening methods, and develop a better understanding of a head and neck cancer patient's perspective. So please note that this webinar is being recorded, and the recording as well as the PowerPoint slides will be made available following the webinar. They will be archived on CIDC's and HPV Global Action's websites. The addresses are at the bottom of the slide, so you can get the recording again. This recording, along with recordings from other webinars and a number of useful resources, may be found on both websites. You can also join the Canadian HPV Prevention Network by completing the contact form online on the CIDC website. Now for some brief administrative notes. You can hear the audio via computer speakers. All participants have joined the webinar in listen-only mode. So to ask a question at any time during the webinar, you can type it in the question panel and click the send button. Questions submitted during the webinar will be saved. All or some of the questions will be answered following the presentation during the Q&A period. Finally, we hope that all participants will complete the webinar evaluation. On this slide, you can see the link for the brief evaluation survey. If you registered and log in with your own email address, you will be sent an email following the webinar with this link for the survey. Otherwise, please take note of this address. I would like now to introduce today's first speaker, Dr. Melissa Henry. Dr. Henry is an associate professor in the Gerald Bronfman Department of Oncology at McGill University. She is a FRQS senior clinician scientist at the Lady Davis Institute for Medical Research. Dr. Henry is also board of director of the International Psycho-Oncology Society. Welcome, Dr. Henry.
Thank you. Good morning, good afternoon, or good evening. Today I'll be presenting on the impact of head and neck cancers, and as well as on its epidemiology and impact on function and on emotional well-being. Without further ado, as mentioned, I'm the recipient of an FRQS Senior Clinician Scientist Salary Award. So head and neck cancers arise from the mucosal epithelium of the oral cavity, nasopharynx, oropharynx, hypopharynx, and larynx. So it's basically comprises of all regions of the head and neck except for brain and skin, although sometimes there are metastases from the skin to head and neck regions or to the brain. In terms of statistics, head and neck cancers are the seventh most common cancer. In Canada, there are 7,500 new cases and 2,100 deaths annually. Head and neck cancer incidence continues to rise with a 30% increase annually by 2030. And the increased incidence is attributable to the rise in oropharyngeal cancer, which is linked to HPV infection. Over the next 20 years, it's estimated that the majority of head and neck cancers will be HPV positive. While head and neck cancer represent only a small number of newly diagnosed cancers, they generally have a poor prognosis. So the mean age at diagnosis is 63 years. 74% are diagnosed in men, so for three quarters. 60 to 70% are newly diagnosed in advanced disease. There's 50% 5-year survival rate in average, and there's a great variability in between different cancer sites. 80% receive surgery, with 15% with microvascular free flap reconstruction, where there's the reconstruction of a defect from the surgery in the head and neck area from a part of the arm or the leg. And 70% receive radiation therapy with intensity modulated radiotherapy, with or without chemotherapy as an adjunct. So this involves 6 weeks of daily radiation therapy, and 6 weeks of weekly chemotherapy. And of course, there's the advent of immunotherapy. So major risk factors for head and neck cancer include tobacco smoking, alone or in combination with alcohol consumption, which is thought to account for 72% of cases. The human papillomavirus is especially important in oropharyngeal cancers, and there's a clear socioeconomic pattern to head and neck cancer, which is not explained entirely by smoking and alcohol. Minor risk factors for head and neck cancer include diet, physical activity, and oral hygiene. So we can imagine that head and neck cancer, given the particular region where the cancer is and the treatments, the treatments are quite invasive. They involve pain, disfigurement, compromised function in vital and visible areas of swallowing, speech, and breathing. And so patients are also at risk for social disparities, psychological distress, and even suicide. It's a treatment that particularly affects the social interpersonal domain because of the central aspects of eating and speech in our social function in life. Treatment recovery takes on average 12 to 36 months, and there are long-term sequelae from treatments. The main side effects from treatments in terms of radiation therapy acutely are mucositis, dermatitis, vasculitis, and lymphedema. And you can see a variety of impacts all along different systems of our physical function and symptoms. And very delayed onset treatments include thyroid cancer, osteochondroma, osteosarcomas, vascular complications, and lymph node calcifications. Now, function is a central, important area to take into account in head and neck cancer treatments, and it's taking into account by the treating team, of course. And function really comprises bodily functions and structures in terms of our physical abilities. But for patients or people, especially, it's important to function in everyday life and in meaningful life roles. Essential aspects of functioning are comprised of 6 areas. There's breathing, speech, food intake, mobility, pain, and mood. And as you can see through this graph, when people start treatment, or before they start treatment, actually, their mood is actually sometimes, they can come in with certain vulnerabilities. So we need to take that into account, because we know that they will be affected pre-treatment through the cancer, and then they will be certainly affected post-treatment in these central areas, and mood will have an important impact on function and physical symptoms. Long-term functional consequences in a cohort of 681 patients with head and neck cancer with a median of 3 years post-initial diagnosis include severe limitations most frequently affecting functional domains of food intake for 1/5, followed by speech in 16%. And this really brings about a whole slew of life changes. So 14% of patients depend on a gastrostomy or feeding tube, 10% on tracheotomy, 10% are not able to communicate by telephone, 7% depend on opioids, 8% are on antidepressants, 4% are not able to drive a car or comb their hair due to head and neck cancer stiffness. So we can imagine the adaptive toll from the disease. And of course, compromised function in different areas are due to stage, tumor site, and treatment predominantly. So the adaptational toll, with the adaptational toll comes psychological distress and emotional distress. And we know that emotional distress is important because it compromises a variety of outcomes: survival, disease-free status, postoperative function, nutritional status, and weight loss, which is particularly important in head and neck during radiation therapy treatments, treatment compliance, recurrence, medical expenditures, use of narcotics, and tobacco and alcohol use. We see here different impacts of head and neck cancer, as someone that had an operation to his jaw, someone a laryngectomy, here to the chin area, the ear has been taken off, and the reconstructive impact on physical appearance of the arms and the legs similarly. So emotional distress is present along the continuum of the cancer trajectory, and these are different points. Now, my research program aims to identify and better conceptualize early determinants of mental health and symptom burden in patients with head and neck cancer. I would like to acknowledge all of my contributors to the different studies in my research lab. And so we're really interested in the early phase and how the early phase and vulnerabilities in the early phase, or can we find markers in the early phase that will contribute, where we can identify patients that need particular support early on. So this is based on the stress diathesis model, where the amount of stress is there from the treatments, but we also have to think about the predispositions or the early things that people are coming in before the disease even happened that may then influence their trajectory of care. So I'm going to be presenting results from a prospective longitudinal study of 223 patients newly diagnosed with head and neck cancer using state-of-the-art structured clinical interviews, psychometric measures, medical chart reviews, and saliva samples for genetic testing. So one of the outcomes we looked at is suicidal ideation, because in the head and neck patients have been reported by certain articles as being at increased risk for suicide, according to large epidemiological studies, for example, published in JAMA. So we were interested in better understanding the proportion of patients with suicidal ideation and when this occurs in the trajectory of being diagnosed with cancer. So these are newly diagnosed patients with head and neck cancer. 16% were suicidal within the first year of a cancer diagnosis. It's huge. And 30% were considered, according to a standard suicide risk assessment, as moderate to high risk for suicide. 50% saw the suicidal ideation onset upon the cancer diagnosis, and 50% along the treatment. So of those that were presenting suicidal ideation during the diagnosis, a lot of them had suicidal ideation in the past, and of those that presented it only in the treatment period or the immediate post-treatment, these were patients that a majority of them, 94%, did not present suicidal ideation previously. So we do see here the impact of treatments, but we also need to consider the diathesis, not only treatment-related burden. And it really brings about the importance of suicide prevention in head and neck cancer clinics. We know that suicidal ideation also is related to poor quality of life function, head and neck cancer symptoms, and head and neck symptoms and complications. We also looked at the prevalence of major depressive disorder, and we saw that 1/5 of patients present a major depressive disorder from diagnosis to 3 months post-diagnosis, which is in the immediate post-treatment. And so this is very, much larger than what the prevalence is found in Canada. And patients more susceptible to develop major depressive disorder immediately post-treatment are patients with advanced cancer receiving surgery alone, having a lifetime history of anxiety disorders, and having high pre-treatment anxiety and depression. So we really need to think early on about what people are bringing into the landscape and to be able to provide them support early on. Major depressive disorders compromises quality of life over 6 months. And the research implication is really, is it, the impact of the disease, of the changes? Can there also be an immunological hypothesis because people are bombarded with very intense treatments, especially radiation therapy? And so there may be also a response that it's an immunological that mimics depression as well in this population. So we also looked at anxiety, because anxiety, as it ends out, seems to be an early predictor of compromised quality of life, compromised emotional quality of life, and symptom burden. And so we looked at the prevalence of anxiety, and we see a very high prevalence. So 1/5 of patients within 2 weeks of a cancer diagnosis presents with a clinically significant diagnosable anxiety disorder, and 16% immediately post-treatment. You may think, yes, and it's true, of course, people are anxious when they're diagnosed with cancer. That's inevitable in everyone. But the level of anxiety also is indicative of what's to come and how people will be struggling. So we need to pay attention particularly to those with a high level of anxiety. And anxiety disorders are fairly stable over time. So a lot of people are actually coming in with a previous history of anxiety disorders that's being untreated. Of course, there's a stigma related to mental health, and people don't necessarily always go for help when they're experiencing high levels of stress. So again, this points to the stress diathesis model, where there's an interinfluence of the medical and larger predisposing context. And so we need to think early on about early determinants of quality of life trajectories.
2 minutes.
Based on this, yes. Based on this, we also investigated the role of genetic predispositions towards depression. Now, we know that there are genome-wide association studies that have found risk variance for depression. And so we wanted to particularly study it in this population as it intertwined with symptom burden, as well as survival in the immediate and symptom burden, particularly in the immediate post-treatment of patients with head and neck cancer. And we know that from an article again on JAMA review, that patients with that depression has been found to compromise survival in this patient population. So what is a polygenic risk score? It's a number based on variation in multiple genetic loci and their associated weights found in GWAS studies, and is the assures prediction of a trait taking into account multiple variation or SNPs. Head and neck cancers affords a unique opportunity because there's the same high stress situation, high levels of psychiatric comorbidities pre-cancer, high degree of disease and treatment related burden, and lower survival. So what we did is that we looked at symptom burden and the ability for genetic predisposition to predict symptom burden, and it did. So apart from the genetic predisposition, there was also a dose of radiotherapy, medical comorbidities, a diagnosis of anxiety disorder, and level of anxieties that also predicted symptom burden in this population. Genetic predisposition towards depression also predicted survival at 3, 6, 12, 24, and 36 months. as well as levels of anxiety, cigarette smoking, and HPV status. So you can see here the large difference between survival in people with different, with the 50th percentile of the 2018 PRS for depression.
Yeah, please conclude. Your time is up.
So in conclusion, yes. So just a little aside that HPV has an impact on anxiety and depression. It also has an impact on quality of life, but especially when people are first diagnosed, but then the treatment takes precedence over HPV status. And we need to pay attention to sexual aspects of HPV. There are clinical practice guidelines also on how to communicate with people around HPV. We need to use the teach-back method to communicate well with patients, for example, for them to better understand what they're going to be faced with during treatments in terms of changes in their bodies. And we also need to think about prehabilitation, where we target diet, exercise, and psychosocial well-being as part of our healthcare system to prepare patients and bolster their resiliency so that they can face this challenge and with minimum or minimal or less intense symptom and side effects. Apart from alcohol, nicotine, and drug cessation, these are especially important in head and neck cancer. So mental health is a great source of health disparities
Henry,
and
your time
inequalities.
is up.
Screening is
So sorry
important.
for that. We have to
We need to
change.
cover the care models, crisis evaluation, and keep in mind this diathesis and treatment response and survival. Thank you so much.
Thank you, Dr. Henry. Our next speaker is Dr. Denis Soulière. Dr. Soulière is a methologist and medical oncologist at the Centre Hospitalier de l'Université de Montréal and a clinical researcher in molecular biologist communicator. Welcome, Dr. Soulière.
Thank you. I'll just try to take control of the slides. Okay. Maybe if I go back. So thank you. So as mentioned, I'm a medical oncologist, but I'm also the medical director of the head and neck tumor site here at the Centre Hospitalier de l'Université de Montréal. Just as a background of information, Notre-Dame, where what used to be a part of CHUM, which is now the biggest hospital in Montreal, but Notre-Dame has a large history of head and neck cancer. It used to be the place where just about half of all cases of head and neck cancer were treated in the 60s and 70s. So there's a large amount of expertise that developed here in our site. So that led to a lot of clinical trials, especially in the context of treatment of head and neck cancer, but also being able to understand the epidemiology of head and neck cancer and how it changed dramatically over the last 20 years. So this is the two sites that I mentioned. So on the left, you see the old Hôpital Notre-Dame, which had the first site of radiation therapy for head and neck cancer, and our new center here on the right. Just as mentioned, I have no conflict of interest of special interest in the context of this presentation. I'm an advisor to multiple companies in the development of therapies for head and neck cancer, and all research money that I get in terms of head and neck cancer goes directly to my institution and not to self. We did mention the different sites of head and neck cancer initially. So head and neck cancer is just not one site. It's multiple sites that you see here. So the nasal cavity, nasopharynx, oropharynx, hypopharynx, and the oral cavity. So these are all sites that are related to head and neck cancer, but each of them has to be actually considered to be a different site in itself. And a lot of what we're going to be discussing today about oropharynx is where a lot of the HPV has effect. So most of the increase that we see in head and neck cancer is related to an increase in the number of head and neck cancer of the oropharynx that are HPV related. There is not that much difference in terms of the incidence for those with a primary of the nasopharynx, oral cavity, or hypopharynx or larynx. So a bit of the epidemiology, it was mentioned before, but I just want to point out some elements again. So that the histology of head and neck cancer is mainly squamous cell carcinoma. So there are not a lot of different types of cancer that we see. So it's basically squamous cell carcinoma. And the primary site of origin is the oropharynx that I mentioned. So even though, let's say, 40 years ago, it was about 40% of the oropharynx, now it's about 70% of cases that we see with a cancer originating from the head and neck region that are from the oropharynx. And out of that site specifically, about 80 to 90% of cases now are HPV related. We cannot say for sure that it's caused by HPV, but we can say that it's HPV related, so that we're able to identify the genome of HPV in cases of oropharynx. As for other sites, so like larynx or oral cavity, it's in the order of 20 to 30%. And we will already mention that the incidence of oral HPV without the incidence of cancer is about 10 to 15 or to 18%. So not that different from just the occurrence of HPV infection in the head and neck region if we look at other sites other than the oropharynx. We can see here that the incidence makes for head and neck cancer as part of the 11th type of cancer, that is the cause of cancer. That's related from the latest survey that we have from Statistics Canada, related to the year 2018 and reported in 2022. You can see here that the number of cases is about 50,000 cases, about a 25-year prevalence of the disease, and a 2-year prevalence of about 10,000. So that means about 5,000 cases a year of head and neck cancer, all sites, including oropharynx, but you do understand that about 2/3 of them are from the oropharynx. If we look specifically at age, you can see with the white arrow here that head and neck cancer starts to arise now in about the 30s and 40s. Whereas before, we never saw that before. The great majority of cases were diagnosed maybe in the 50s and 60s, not necessarily 70s. But with the occurrence of HPV and more of the oropharynx being present, we see that the age of occurrence is younger than it used to be. We're not exactly sure as to why this happens. So what is the time from infection to HPV to the time of developing head and neck cancer? That is not something we're exactly able to say, but we do see that there seems to be an increase in the number of cases arising at a younger age. And as I mentioned, that is mainly because of the oropharynx cases. What we do see, however, is that even though there's a number of cases of different types of cancer that are lower in incidence when it's adjusted for age, well, for head and neck cancer, it is on the rise. And especially for males, we do see here that there is an increase for that type of cancer. As for other types of cancer like testicular cancer and melanoma that are known to have arisen quite significantly over the last few years. This is also true for females, for women, but not as much. It is within the margin of error. So the number of head and neck cancer has maybe slightly increased for the women population, but not as much as for males. And we can see here that when we look at the probability of developing head and neck cancer, for males, it's about 1 in 46, whereas for females, it's 1 out of 114. So a disease that arises much more in men than it does in women. And here you do see again the number of cases that we see per year. So head and neck cancer, about 700 to 500 cases a year in Canada. And you can see that the number of cases for males compared to females is much higher per 100,000 members of the population. It's about triple the number for males as it is for women. In terms of the numbers of deaths related to cancer, we can see that head and neck cancer represents about 3 to 4% of cases of death for men, whereas for women, it's not in the first, it's probably less than 2%, so in order about 1.5%. If we look specifically at oral cancer compared to larynx, we can see here again that in the latest statistics, we do see that oropharynx, as I mentioned before, is the highest incidence, so about 2/3 of cases compared to about 1/3 of cases for the rest, so of larynx or hypopharynx or oral cavity. So let's talk about the transmission of HPV. Oral HPV is either acquired through sexual habits or as a fetal-maternal way of transmitting it. So if the mother has HPV, in the cervix area, even at birth, it is possible to transmit the HPV, and that is possibly one of the reasons why we have oral transmission of HPV. The epidemiology, as I mentioned, in North America, the cases of oropharynx cancer that are HPV related is about 75 to 90% out of the latest statistics. And that has increased significantly over the last 20 years. When I joined our institution about 25 years ago, and we went back to look at that, it was about in the order of 30%. Now it's about 80 to 90% of cases of HPV that are oropharynx that are HPV related. There are differences. We see that in Western Europe that is still around just about 40%, but it is on the rise, and it is expected in about 20 years they will have the same percentage of HPV-related OPCs that we see here in North America. And in Eastern Europe, they're still at about 10 to 20%. So not a lot of transmission that happened in that part of the world yet. If we see, though, the incidence of oropharynx cancer as it is recognized in the world, and we see that oropharynx in the latest statistics in 22 of the Institut National de Santé Publique du Québec was about 70% of cases of oropharynx were HPV related, and you can see that the cervix cancer was 100%. So there's almost no cases of cervix cancer that is not HPV related, but we do see about a certain number of cases that oropharynx cancer that are not HPV related. So what you see here is the number of cases of cervix cancer on the decline over the last 20 to 30 years. And that is the total incidence as well as the number of different cases that were reported. But if we look at oropharynx cancer for women and for men, we can see a marked increase that happened over the last few years. So you can see here for the less than 60, over and 60, and the overall population, we can see an increase in number of patients who have oropharynx cancer that is HPV related. If we look at the same time, we see that those with a cancer of the oral cavity, there was no change overall over time over the last 30 years. So even though there is more HPV in the oral cavity, it doesn't seem to have that much of an effect on the oral cavity type of cancer that we'll see. It seems to be mainly related to oropharynx, and it's also true for larynx, where actually we see a decline in number of cases of larynx cancer, both for men and women, even though there is an increase in the number of oral cases of HPV. If we look at the incidence, not just the prevalence, but incidence of oropharyngeal cancer in men, and we look at men in Canada and the US, we can see that over the last cohorts that have been looked at, there is an increase that seems to be really happening, totally related to HPV. So oropharynx cancer and HPV are totally linked for men. In terms of the etiology, is HPV the only thing that can be put in cause? Well, out of this study that we did a few years ago, we did show that if HPV is present, but also if the people are smoking, then there is a marked increase in the probability of developing head and neck cancer, and especially oropharynx cancer. And if it's the HPV genotype 16, then that increases that likelihood by a factor of 50. It is also true not only of smoking, but also of drinking. And we have the same phenomenon of about a 5-type rise compared to the general population and risk of developing oropharynx cancer if you do have HPV and are a drinker. And that is increased by a factor of 50 if you have HPV 16 in your mouth and are also a drinker. I'll skip this in the interest of time. So over the last few years in the US, looking at statistics, of types of cancer that are HPV related. For women, cervix still remains the major element. Oropharynx remains a minority there. But for men, oropharynx represents the great majority of cases that are HPV related, and the anal type of cancer remains a minority. We do have a randomized trial that have been looked at to see what is the type of cancer, the type of therapy we should be using for oropharynx cancer over time. And we cannot say for sure that there is any difference for the HPV-related or not HPV-related oropharynx cancer. What we know is that the use of chemotherapy in combination with radiation therapy has really become the norm and has taken away the concept of surgery really for advanced oropharynx cancer. Why? Because oropharynx cancer surgery was extremely mutilating and causing a lot of side effects over time, whereas chemoradiation therapy, even though it has side effects, seems to be less mutilating and has less long-term side effects compared to surgery. And we've seen over time that the use of concurrent chemoradiation therapy is really the way to go, so that chemotherapy given before radiation therapy or after radiation therapy does not have the effect of chemoradiation therapy effect. Sorry. Why do I mention this? This is because this type of therapy is probably the most severe type of therapy that you can have for cancer, any type of cancer. If you are receiving chemo and radiation therapy, the likelihood that you will have a grade 3, grade 4 toxicity is more than 90%. You don't see that for any other type of therapy. It is mainly mucodigestive type of toxicities, but also hematologic, and a lot of people will require hospitalization. This is data that we did in our institution, looking at 3 types of chemotherapy given at the same time as radiation therapy. And the mucodigestive can be either dermatitis, mucositis, nausea and vomiting, diarrhea, but a loss of weight of 10% in more than 40% of the population, and requiring a nasogastric feeding tube for a period of 2 or more weeks for a good portion of those patients. If we look at the comparison over time of that type of therapy, so chemoradiation therapy, at least in our hands, gave us 63% chance of not having a recurrence of cancer over time at 3 years, and that is pretty good compared to what has been reported in the general population by other groups in Europe and in the United States. And it fares very well compared to surgical treatment of head and neck cancer. So we see that 63% compared to about 50% at 3 years of follow-up for those patients treated with chemoradiation therapy for oropharynx cancer. If we look back at data that we have from the SHIM on the incidence of HPV, so we looked at a number of about 250 cases, and we look at different types of primary, and whether or not they were HPV related or not. So this is data that dates from even 10 years ago, and even at that time, we had a large incidence of HPV positive cases compared to HPV negative. If we look at the stage, it does show that those with a lower stage did better over time compared to those with a higher stage of the disease. But what we see is that the oropharynx cancer are doing much better than the other sites in terms of the primary. And if you are HPV positive, then the likelihood that you will respond good to therapy is better than if you're HPV negative. So HPV is prognostic, but it doesn't mean that we can per se reduce the amount of treatment. It means that for the same amount of treatment, you will have a better outcome.
Please conclude.
Yes, and this is also true, saying that the HPV-16 are doing much better than the other types, other genotypes. I'll skip to that. So it led to a modification in the way we're staging HPV positive oropharynx cancer, so that now most of the stages that were differently looked at seem to have the same prognosis, so that we are able to, even though we're not changing treatment, it did change the staging in terms of the prognosis. In terms of being able to diagnose this pretty early, the use of liquid biopsy was also used. I'm going to conclude in a few seconds. So the use of biopsy, liquid biopsy was used trying to find HPV, and this is still not up to date. So we have a great specificity that if the test is negative, it's truly negative. But if it's positive, there's the likelihood that you're missing quite a few cases. In terms of what we have to say, the vaccination is good in terms of HPV and should probably be the norm in order to be able to get rid of HPV-related OPC. We see that there was a marked decrease in cervix cancer, and we would be expecting the same type of decrease in head and neck cancer, especially for men. So you see that this increase is what I presented before, but we know that there is, as I mentioned, up to 11 to 18% of HPV being present in the mouth, and up to 1.8% of those are HPV-16. And we know that vaccination is pretty good so that it can get rid of 88% of infections in the oral cavity or oropharynx, therefore probably reducing the possibility of having head and neck cancer as well. So in conclusion, HPV-associated OPC is on the rise, mainly in men, and it has obtained epidemic proportion. The treatment causes severe side effects and long-term sequelae that were presented before by my colleague, and there is no reliable test to screen for HPV-associated OPC up to now. Vaccination probably should be the main means to stop this epidemic. There shouldn't be any age restriction. The transmission is caused by people of any age, and the prevalence of HPV being more than 10% in the oral cavity or oropharynx does call for a large vaccination effort to stop transmission and possible development of the disease. And I'll conclude with this. Thank you.
Thank you, Dr. Soulière. Our next speaker is Dr. John Peter Bradford. John Peter is a head and neck cancer thriver and advocate. In his career, he has worn many hats, including a social activist, patient advocate, psychotherapist, mediator, businessman, management consultant, scientist, full-time palliative caregiver, and an author. Welcome, John Peter.
Thank you very much. Give me a second here while I get my webcam on, okay? And just waiting for my slides. While I'm waiting, I want to tell you that I'm going to take 7 minutes to talk to you, and I will not show you one number. I had cancer, head and neck cancer 13 years ago. I drink constantly because I have very little saliva. You can see from my neck that half of my neck is missing because I had surgery. I had very intense radiation. And I have lots of other side effects, or sequelae as they call them, and it doesn't matter. I'm happy as hell, and I'm very happy to be here. So the first thing I want to tell you is you have gifts. I have gifts. My gifts were, you know, I'm a psychotherapist, so I understand a little bit about managing emotions. I was a mediator. I was a businessman. I know how to make deals. I am a scientist. I publish in an oncology journal, so I understand science. And I'm a hack musician, so I can actually play music and make myself feel good. I brought all of those gifts to the treatment process I went through and to creating a partnership with my physicians and with the people in my life who are my support network. You should do the same thing. Use your gifts and bring them to whatever you're going to go through. So I guess I can, oh, here we go. So I got to find the right slide here. Okay. So the first thing is when you're diagnosed, make sure you understand all the options. The standard of care, which is what people just give you, may not be the right thing for you. Standard of care is something that's been approved and everything else and is often behind the times. In my case, I got a therapeutic treatment that was experimental, but it worked in my case, and I chose it on purpose. Explore your options. You already know all the various kinds of therapies. People have talked about them. So I'm not going to go through this in any detail, but there are 1, 2, 3, 4, 5, 6 separate different ways of treating head and neck cancer, and they are used often in combination. When you're being diagnosed, whoops, okay. Somehow we missed a diagnostic slide. I found my radiation. I found my cancer. The doctor didn't. And my diagnostic process was way too long. I had to push the hospital. I had to become an advocate. You must become your own advocate, and don't worry about hurting people's feelings. Be kind, be a rainbow, be gentle, but be persistent and understand your options. I won't go into any of the gory detail. The side effects, whatever they are, don't define you. They don't define me. I had mind-numbing fatigue. I had brain fog. My throat was so sunburnt from the radiation treatments that there was blood running down my throat every day. My head and my neck were so burnt that my wife had to cut the shoulders on my shirt so that they only touched this part of my skin. I had no saliva. I could not taste anything, and to this day, I don't taste much. I lost all tolerance for spicy foods, which I used to love. Still don't have it. I am disfigured. I have a crooked smile. This side of my face doesn't, this side works fine. This side here doesn't work so fine. My neck doesn't work right. A lot of nerves were cut. There's a whole kinds of side. I have hearing loss. I wear hearing aids because of hearing loss associated with radiation. But none of that defines me. It shouldn't define you. What defines me is what's inside me and what love I have to give to the rest of the world and what joy I can find in every day and what productive things I can do. That should be your goal. That should be how you should carry yourself through facing cancer, and be compassionate. Be kind all the way through. Don't feel sorry for yourself. Don't succumb to this thing that Michelle talked about, which is, all this depressive things and stuff. There are ways around that. Right? So when you're doing your treatment, diet, nutrition, and a reasonable amount of exercise are extremely important. You don't want to lose weight. You don't want to lie around and feel sorry for yourself, but you don't want to overdo it either. And then my advice is, if you can avoid a feeding tube, don't get it, because a number of people that I've worked with have had feeding tubes and then they have to learn how to swallow again. As it is, if you had the treatments I've had or something like them, your swallowing response is going to be compromised anyway. So why make it hard on yourself? My wife used to take a complete dinner, throw it into a Vitamix blender, turn it into slurry, and I would slowly gulp it down instead of having what was the recommended feeding tube. So this is something that's it's important to keep your weight up. It's important to keep active mentally as well as physically, but not to overdo it. I wrote a book while I was and wrote music while I was in treatment and recovering, just because I needed to keep myself active, and I would walk every day, even though it killed me. It didn't kill me, but because it made me tired, but because I knew I needed to keep some level of energy up. The most important thing, though, if you have head and neck cancer, is to have a support network. And that support network has to have some things in it that are going to help you. The first is you need the caregiver, who is your primary caregiver or caregivers. They are there to provide love, receive love back from you, to provide support. Could be physical support, could be emotional support, could be dietary support, and to gatekeep, to make sure that you're not doing too much, that you don't have too many people coming to see you, that you're not doing too little, to gatekeep. Secondly, and if you need a person, sorry, I don't have any saliva, so I have to drink here. Someone who's level-headed and smart, who can go to medical appointments with you. That person should take notes, ask questions, synthesize information. No matter how smart you think you are, or no matter how level-headed you think you are, or no matter how emotionally calm you think you are, you're going to miss stuff because you're in the middle of something where you're being treated. You're in a dynamic with the physician or the technician, and you need to be able to have an independent view so that afterwards you can discuss stuff, you can reflect on it, you can ruminate on it, you can do this. Another thing is make a partnership with your physicians. Don't just go in and be a lump. Don't be a passive patient. I created partnerships to this day, which 13 years later, I still have the same relationships with these people that treated me, and I published with one of them. So it's important to create a relationship where you care about the other person and understand where he or she is coming from, and she or he cares about you and where you're coming from, and you're working for the common good, which in this case is you getting better. You should have people in your life that call you, who write to you, who visit. They provide emotional support for you. They can provide fun for you. I mean, play music or laugh. People who can think with you. People who just provide relief for your primary caregiver so they can go out and have a life and recharge. You need people to shop. You need people to make food. Because if your primary caregiver is also working or has other things to do, this is a huge load to take care of you. You need people to drive you to places. Like I had radiation, 35 appointments, can't remember the number, but some large number of appointments every day. And it took an hour and a half out of my time. By the time we drove there, sat in the waiting room, blah, 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 came out, got home. My wife didn't have to do that because I had people who were dedicated drivers, my friends. I got to know them better. They got to know me better. We got to be in the waiting room together. We got to know the people in the waiting room together, right? Don't be an island. Don't be closed up. Open yourself. Surround yourself with people who complement your gifts and your skills and your support network. Oops, went the wrong way. So, all that said, I'm quite willing to have any questions, expand on any of this, but encourage everybody you know, from teenagers on up, to get vaccinated. I received a broad spectrum vaccination after my treatment, but I think everybody should be vaccinated. There should be no stigma attached to it. It just makes perfect sense. Remember, your support people gave of their lives to you, took time out of their lives for you, put energy into your care. Give it back. Give back to them, give back to others. I run the Life Saving Therapies Network to give back, to find better therapies more quickly for people in a whole range of cancers, lethal ones in this case. Help others navigate the system. The medical system is not easy to navigate, and anybody who's worth their salt, including physicians, will tell you you need to be your own advocate. And a good physician will welcome you as an advocate partner with him or her when they're treating you. If you have the predilection, please help change the policy in Canada so we can get faster access to better treatments for people. I have a whole long-winded speech about that. I'm not going to give it. I'm not going to give it to you now. I had stage 4 cancer. There are two different kinds of staging cancer, ways of staging cancer. It can be by how big it is or how far it's spread in your body. Mine was staged by size to be stage 4, which is the highest, worst stage. And it had gone through all of this side of my neck, and it had not metastasized yet beyond what's called the local ENT region. But I had a lot of lumps. So I was very, very lucky because certain of the therapies could be used. But the most important thing is that it didn't drive me into the ground. It didn't make me a Debbie Downer. And I'm asking you, whether you have cancer, head and neck cancer, whether you're a support person for someone, whether you're just somebody who's interested, whether you're a physician and you've got 40 clients in a day or some ungodly number of people to see, remember, everybody's a human being. Everybody has gifts. Everybody has cloudy days. And you can be a rainbow in their clouds. You can bring love and inclusiveness to their lives and to your own life by doing it, and to eradicate the part of the psychological part of life, fear, that brings people down, predisposes them to mental health problems, and makes it more difficult for them to deal with the cancer they've got. That's it. Thank you.
Thank you, John Peter, for your presentation. We will not have time for questions and answers, so I would like to thank Dr. Henry, Dr. Sulia, and Dr. John Peter for their excellent presentations. And it's been a pleasure working with you on this educational webinar. I would like to remind that we are very pleased and appreciate the support of Merck Canada that allowed us to bring this webinar to you at no cost. And please remember to complete the evaluation survey by clicking on the link in the follow-up email that you will receive shortly. Note that this webinar has been recorded and that the video recording and slide set will be available on CIDC and HPV Global Action website the near future. These and other resources are available on both websites. So thank you for your interest in our webinars, and please plan to join our next free webinar entitled Low Risk HPV is Not No Risk HPV, Anogenital Warts and Respiratory Papillomatosis in Male, to be broadcast on Wednesday, September 13th at 12 Eastern Time. You can see the registration link on the slide, and please watch for a notice. We hope you can join us, and more details may be found on the CIDC website, cidcgroup.org. So again, thank you very much, John Peter, Denis, Melissa, for your excellent presentation on this special International HPV Awareness Day for head and neck cancer. That's all for now. Thank you.
Thank you. Goodbye.
Thank you.
Bye.